indicator trying to tell us where are the resources needed and in which department and what kind of specialty we need. Then the second question was, is it fairly distributed? So here I'm showing you only vulnerable people. So we have in blue, the blue dot, the one that are typically on the left, are the children under 5, and then the red and the green one are elderly people. And what you see clearly is that for some disease, if I take respiratory disease, it's really driven by the elderly. Right? So it shows us metabolic disease as well. It's really the elderly responding to those very high temperature and not necessarily the bulk of the population. I mentioned this IMD, this index of multiple deprivation, and here what it allows us to show is that who is really responding to this shock. And the most deprived are in red, and when we see this extreme and the red dot being basically larger than the blue one, it tells us that the burden of disease is not equally distributed. So this is just in a snapshot how we can quantify the effect. Then we did just a different kind of work just to show how it affects capacity. And here we were trying to understand when, because of those shock, hospitals become over capacity. So you can see that as soon as we are in the red orangey-ish, we are over capacity. And clearly all the hospitals are significantly impacted by this. Now, I can put this in numbers, excess admission of above 1 million, but over that period, it's mainly driven by the cold days, rather than the extreme hot. Oh, sorry, it shouldn't be 89, it should be 9.7, sorry, that's a typo. What we see is that typically hospitals get above capacity, which is something that is extremely costly, prone to error, and really makes the situation worse. Overall, this is 20 million excess admissions per year. Is it a lot or not a lot in the grand scheme of things? Remember, we're only looking at 6 diseases. We're extremely conservative in terms of the net effect. So this is really above everything else. So, and it's an easy one to prevent, right? So we've compared this to different budgets, whether that's meaningful or not. Typically, that's 10% of total hospital bed days. This is an average, which means that for certain hospitals, it's much more than this and very hard to deal with. And the last point is that we've seen that there are really wide inequality that should be addressed. So, what do we do with that? It's likely to get worse in the future. It suggests that we need to implement policies that do address this typically cold spell vulnerabilities. In UK, we have what we call the winter fuel payment. So poor people get a top-up to pay for their energy bill, which should keep them warmer. Whether that's effective or not, this is a project we're working on, trying to understand whether the money was spent as it should have been spent, because if these people are deprived, they might spend it on food, for example. So what we want to see is whether we see a reduction in those hospital admissions as a result of those winter fuel payments. So these are the kind of intervention we can have. Let me just flag a few things because I'm almost out of time. This approach can be done in a similar way with pollution exposure, but it's much more complex because of the distribution of pollution. Method, my colleague is going to talk about the challenges. We've done some work on that. What I wanted just to show is that depending on the model we use, we might over-predict or under-predict pollution exposure. It's much more tricky to assign and to model, but that's something we are doing. And now just to conclude, so what do we do from that? What do we take from that? I think what is essential is that there is such a range of intervention. We shouldn't just think, oh, it's costly and how are we going to deal with that? We don't have the money. The very first thing is monitoring. I think we have no excuse with AI now and with all the tools we have. We have to monitor what people are exposed to. We need to be able to anticipate. This is really low cost. Being able to inform people, to tell the elderly, don't go outside, it's going to be very hot. This is a very easy peasy solution. So informing people, measuring our progresses, and then we know what the problem is. So policies and regulation are essential. Part of my work is on the ETS, so those permit to pollute. How is that sufficient? The answer is no. We need much more than this in order to put us on a track that's sustainable. We need to really be aware that it's unfairly distributed across the population. So really some people are the ones that are typically affected, and we need to invest much more in those in order to prevent those cases. And then it's essential that we adapt, and because this is just coming and just getting worse. So more work on this, more research for me, and thank you very much.
Thank you, Dr. De Preux, for your presentation. I do have one question regarding the misclarification of environmental bias. How did you manage to reduce it, knowing that each patient does have the same exposure and may have a differentiation of its exposure due to maybe AC in the environment, or also the indoor temperature difference between the outdoor?
Yeah, so we don't observe it. That's a very good question. We don't observe indoor and outdoor, right? What we know is where people are admitted. So that's the first thing that we have to make decisions, because you might be admitted in one place because you were on holiday. So we really modeled the pollution where people were admitted, because we felt it was a better assumption. You were typically admitted for an emergency admission in the closest location, right? So we assign to those people the temperature around the hospital. Whether people have been driving 200 kilometers to go to that hospital on that day, this we will never know. So that's one limitation. Whether the person, whether my grandmother would have been admitted even though she maintained the temperature very low, we don't see that. But in a way, what we know is that first it's an underestimate. Second is that if people are still admitted, whatever they've been doing, then from a hospital perspective, they need to anticipate the resources. So I think the number are extremely useful from the hospital perspective, because that's the smallest estimate in a way that they can expect. Everything else will just be worked and exacerbated by those temperatures. So it's true that we can't disentangle that.
Yeah, I had a second question regarding the application of your study to Belgium. Knowing the density is really different from London, how could we switch from these two cities, taking Brussels as example?
I think you can, I don't have the numbers for Belgium, but I think the magnitude of the effect, realizing we are talking about 10% on average on those days, plus a lag. So this is just the bulk of the estimate, trying to give direction even for Belgium. It's going to be very similar. They can apply the temperature that we've chosen, the temperature bin, the temperature threshold that we've used, 35, but what is interesting is that we see an effect already from low temperature. 25 already people start showing up in hospital, right? So whether you are in UK or in Belgium, that's relevant. We were told at some point, why don't you use deviation from local temperature? But human body doesn't really adapt, right? We all start suffering from fairly similar level of temperature. So one thing you could be concerned of is that whether Belgium has more air conditioning or, is very different. But I think they are very similar. So the bottom line is that they will face more or less similar kind of excess emission in those days, right?
Thank you so much for your presentation. I had, let's say, a question in order to reconcile some of the results that you have. So first you said that the excess admission is mostly driven by extreme cold events, yes, right? And then in the results by diseases, it seems to be mostly driven by extreme hot events.
No, because you have more events with cold days. So this is on a day with, that's a good point. This is on a day with temperature above X. So you see, so the dot here is 15, 20 degrees, which is the temperature that we're all most comfortable with. And then you see deviation, you're right, it seems to be driven by hot days, but we have a lot of cold spells. So when you look at the number where the bulk of the effect is coming from, it's really from those cold exposures, but that's a good thing. But so it's worrying, because if we have more days with those hot temperatures, then it's just going to get driven more by the hot days. Yes.
Okay. Thank you so much.
Yes. Thanks a lot for the presentation. So I work for Cienzano, the Belgian Public Health Institute. I specifically liked your remark that we don't have any excuses anymore for not monitoring and not knowing what's going on. So we're currently doing work to look at the burden of disease, like the health impact of heat and environmental stressors. I think what could help us also is to be explicit in how this information is actionable. So I was wondering for London or in the UK how hospitals are now able to be prepared for these heat events, and maybe what kind of actions they can take with like a few days, like knowing a heat wave is coming. Like, is there anything they are doing now?
I don't know is the short answer. I don't think they do it in terms of resources and anticipating it. We're doing a bit in terms of warning system. So, you know, alerts, when you're looking at weather forecast, then you will be told, you know, tomorrow is going to be a hot day. They start having also air quality index, trying to warn people it's not the best day tomorrow to go for a run if you have asthma, for example. So, you know, people will self-select and decide what they want to do. But I don't know is the short answer in terms of healthcare resource allocation. But I don't think they, you know, they do it. They don't. I don't think they take that into account, unfortunately.
Thank you, Laure, for presenting this. I have a couple of questions and.
I can see you. Sorry, where are you?
Sorry.
No,
it's me. So thank you for presenting this. I have a couple of questions. So, I mean, I was surprised when I look at your results. I mean, all the others make me perfectly sense, but do you have any explanation why you don't find effects on circulatory diseases and why you find effects on respiratory diseases? It looked like more on pollution effects than temperature effects. And then I was wondering whether you found any harvesting effects or people that would have died in any case because of temperature, given you mentioned you have leads and lag estimates. And then I have a question, given that I've been working on similar work in UK. I know they basically they have no air conditioning. Buildings are mostly designed to retain heat instead of releasing it. So that's a big issue in the UK, I know. So how do they deal with that?
So, the first question, you were surprised with which results? Sorry, I didn't know which disease you were surprised about. Yes, so circulatory disease, so it's a big group. In the appendix, actually, of the paper, we split it between different subgroups of circulatory disease, and some have no response, and some do have a large response. So this is hiding some of the very specific effects, yes. Your second question was about... Yes, so the harvesting effect. What is harvesting effect? We don't look at mortality here. So, harvesting effect means that, especially in the case of mortality, means that we have an excess mortality on that day because it's hot, but then we see a decrease in the next days. So in a way, people have been harvested sooner, but overall, you know, if we were expecting 100 people to die in 1 week, whether we have 50 dying now and now 50, you know, even. So we just precipitate basically their deaths, but overall we haven't really caused more deaths in the short term. That would be the harvesting effect. Here we have no harvesting effect in this, which just means that in total we simply have more admissions. We don't have people showing up that would have shown up anyway later. We see an effect, and then when we look at the following days, it's stable. So it's not that somebody was just injured themselves earlier than they would have. No, they zero harvesting effect in the context of morbidity. Mortality, different story, yes. But we don't have that. And then your last question was about pollution. So we have massive problem of insulation. Things have just going worse, because UK is just going worse anyway. Things are just going worse because they had a scheme to isolate houses, but they've done it in such a bad way that the isolation they've now put outside the houses is retaining humidity and transferring humidity. And we all know that for air quality, having mold and stuff Indoor is dramatic. So we are not working towards the best solution at the moment, but you know, all we can see, but that's why it's very interesting, is to understand where do we have excess admission. If they're driven by the poorest area, then that's really a big concern. That suggests something is happening to where they live, which doesn't allow them to be resilient to that extreme weather, right? And this is exactly what we see, is that the poorest people are the ones showing up in emergencies, which suggests that probably their environmental, their infrastructure where they live isn't suitable, and typically retain the heat, let the heat come in the summer, but in the winter it's the opposite effect, right? They can't maintain heat, and it costs too much, and then eventually they come up in distress and have all sorts of issues. So prevention, yeah, there's so much more we can do. We're doing it right. We tried to do it, we did do it right.